So I alluded to the fact that some of the mutation patterns that we see in MDS are relatively characteristic of the disease. And we know that there are some patients in whom we suspect have MDS, but when we go through our evaluation, including a bone marrow biopsy, we don't necessarily have the criteria that meet the diagnosis. So what we'll do in some of those cases is actually sequence their blood or marrow to identify those mutations that they carry. And we've learned two things. One is that if you can't find a mutation after looking at a large number of genes, then that patient is less likely to progress to an overt malignancy. So you can feel reassured that that patient is more likely either to have some other cause for their cytopenias, or that their cytopenias are unlikely to develop into something more concerning. The other thing we can learn is what the risk of developing a subsequent disorder like MDS might be. And there's certain mutations that we think are more worrisome. So as I mentioned, MDS is a disease of the spliceosome. So if we see mutations in splicing factors or mutations in high-risk genes like RUNX1, then we can assume that those patients are more likely to progress to disease in short order. And in fact, we may, in the future, end up treating them as if they had lower risk MDS to begin with. The prognostic side is a little bit more well established. We know that there are mutations that tell us something about our patients that we didn't already know by looking at them in the clinic or looking at their labs. And we're having to work about how to put that together with that clinical information. So some mutations tell you something about the patient that you already knew. They might correlate with complex karyotype, or they might correlate with excess blasts. And some of them give you some additional information. So as a community, the International Working Group for MDS is coming together and doing studies to look at how best to integrate mutational information into clinical prognostication. And we're going to, hopefully in the next 12 to 18 months, come up with some consensus method for doing this that'll be the next iteration of the International Prognostic Scoring System.